Hey there, everybody. This is Justin Kletcher. I'm a fourth year, and I'm going to be doing the Drugs and Bugs MedSteps for your Disease and Defense course. The concept of this MedSteps is more to kind of give you all a background and kind of a foundation to start building some of your microbiology and infectious diseases education on. There's a lot that goes into this, and I really want to emphasize that I made this PowerPoint with kind of the mindset of it being a base for which you to build upon. I hope it's something that maybe you can come back to as you start doing step studying and stuff like that. I tried to, cut out as much of the extraneous um, fat per se, and kind of keep in the really important stuff. That being said, I did kind of remove a couple of things that y'all learned in class that will be on your test this week, but I did not include in this PowerPoint mostly just because I felt they were things that didn't necessarily fit cohesively with the theme, and they aren't really things that I feel overly confident, kind of sharing with y'all. So those topics are going to be the NSAIDs, the acetaminophen, and the pharmacokinetics lectures. Everything else, though, should be based off of kind of what to expect on the test, as well as kind of the things to look out for on step. All right. So this all being said, let's go on ahead and get to it. All right, we're going to start off with bacteria. As you all know, bacteria make up a large portion of the microbiology that we see disease in. And so, the key here is to kind of create a foundation for which you can apply as you learn more of the specific bacteria moving into the organ systems in your second year. Okay, when talking about bacteria, we really have to distinguish the difference between gram-positive and gram-negative bacteria. These really define the two key different types of bacteria that we're going to see cause disease. There are some exceptions to this rule, but the vast majority fall either into the gram-positive or gram-negative category. So when we say something is gram-positive, what we're saying is it stains violet with a gram stain. I've kind of shown a simple diagram of that process, and really the idea is you're putting on this stain that binds the peptidoglycan of the cell wall, and really it binds everything. The iodine helps fix it to the cell wall, with the alcohol removing anything that wasn't bound to the cell wall. And then finally, the safranin is a counter stain that doesn't necessarily stain gram negatives per se. It actually stains everything, but the gram positive stain, the crystal violet, actually overrides it. So in the case that the crystal violet has been washed out in, say, a gram negative organism, you now are able to see the safranin. However, in a gram positive organism, that crystal violet is not washed out, which is why you can't see the pink. That's just a key thing. There's nothing about the gram negative structure that makes it stain with safranin, whereas gram positive doesn't. It's actually the opposite. Okay. Again, though, the key element of the bacterial cell wall is the peptidoglycan layer, which is a complex polysaccharide sugar. It's very different from kind of what we see in our own animal cell structures, which is a key element for how we treat bacterial infections. When talking about gram negatives, though, it is important because gram negatives, by virtue of having a different type of outer layer, cannot be treated with various antibiotics that we would typically use. Another key element to keep in mind is that there are two lipid bilayers in the gram-negative bacteria, which creates this periplasmic space on the inside. This is where you see a very small layer of peptidoglycan. Mostly they're just to provide structure of the bacteria. However, this is also where you're going to find a lot of the drug resistance mechanisms. For example, your efflux pumps are going to mostly be sequestered within this region that are going to pump drugs out of the bacteria so that they can't affect them. This is also where you're going to find beta-lactamases, which are going to break down the penicillins that would normally work against a gram-positive organism. So keys here are just really distinguishing the two, the peptidoglycan layer, as well as some of these elements of gram-negative bacteria that you don't see in gram-positive. Another thing is lipopolysaccharide is only found in gram-negative, and we'll talk about that a little bit more when we get to endotoxin. All right. That being said, there are bacteria that don't fall into either of those categories, and we typically call them atypical. Um, and really, all this means is for whatever reason, they don't gram stain. And that could be for a variety of reasons. Some are just so small that they typically don't stain very well. Legionella and Rickettsia being the prime examples of these two. They have gram-negative structures. However, they're so tiny that you can't really see them on the microscope. And so we would say they are gram-negative but stain poorly. Another type of bacteria is Mycobacterium. They get their name from myco in reference to fungus, in that their cell wall structures contain mycolic acid, which are quite similar to fungal cell walls or um, lipid structures. Um, and so for these, we would use a acid-fast stain for tuberculosis in particular, which is kind of the typical acid-fast bacterium that we would think of. We would use the uh, Zeal-Nielsen stain. However, knowing that name is really not that important. I would just keep acid fast in mind. I provided kind of just an image to kind of give you an idea of what acid fast looks like. Sometimes it's described as these red snappers. To be honest, I really don't know what that means, but it's the term that the pathologists and the histologists like to use, so it might pop up. But really what you're seeing is this blue-black background with the mycolic acid staining purple. Other notable acid-fast organisms are Nocardia and Cryptosporidium. Mind you, Cryptosporidium is not a bacteria. I just listed it here because it does pop up occasionally on boards. It's actually a form of protozoan that particularly inhabits the intestines of HIV-positive men and immunocompromised. And then finally, another source of the atypical bacteria are those that don't have a peptidoglycan cell wall. The prominent ones being mycoplasma. I've shown an image here. What's unique about them is they actually have no cell wall whatsoever. It's just a lipid bilayer. And so if there's no cell wall, there's really nothing to gram stain. So these don't necessarily gram stain. And then chlamydia is a really weird bacterium. It's actually almost like a virus in and of itself, in that it lives with inside cells and forms these kind of elemental and reticulate bodies, and they just don't really follow a lot of the rules that typical bacteria would follow. So you're typically not going to see them gram stain, mostly because they live inside of your host cells. It's kind of hard to get the dye there whenever they're inside of a host. So you're not going to see them on a gram stain. And so when we use these terms, atypical, this is kind of what we're referring to, something that doesn't necessarily have a cell wall. Okay, there's a lot of things that go into classifying bacteria, and this list is not exhaustive. I really wanted to try to hone in on what is important to know. Hemolysis probably being the thing you're most likely to see. When we're talking about hemolytic patterns, we're referring to streptococci. And really, this is just a way to distinguish from the group, the alpha hemolytic streps. And so what happens here is the strep lacks the toxin to completely hemolyze blood whenever it's grown on a blood agar. Instead, you'll get partial hemolysis, and so you don't see a complete clearing. You'll just see kind of this green discoloration where the bacteria are actually growing. These make up your strep pneumonias and strep viridans. One way I always remember that is the viridans is actually Latin for green, and so it kind of forms that green pigmentation. It's very important to keep the strep pneumonia association with alpha hemolytic strep. I'm trying to use kind of some of the color coding that Sketchy uses, because I know some of y'all are going to be using that when preparing for STEP. And I want to say they use almost this exact same visual mnemonic. So hopefully y'all can associate the green and the alpha and strep pneumonia. And then there's beta hemolytic strep. And I've used the highlighter function here to try to kind of mimic the hemolysis zone that you see in beta beta hemolysis. What this means is you've completely hemolyzed the blood cells, and so all of the blood surrounding the area of growth have just dissipated. These are going to be your group A streps, so strep pyogenes, strep agalactiae. That's group B strep as well, but group A strep is pyogenes. So strep pyogenes is what we typically think of as strep throat. Pyogenes, basically meaning fever-inducing. So this is what's going to make most of us really sick. And then strep agalactiae is typically seen in as a commensal organism in the vaginal environment of women, and it can be a huge issue when having vaginal birth because it can actually infect the baby during the birthing process. And then finally, there's gamma hemolytic strep. These have no hemolytic activity. As you can see here, it's just the cultures. There's no partial hemolysis like you see in alpha. These are going to be your enterococci as well as strep bovis. They're not typically going to be popping up on your exams asking you to know that they're gamma hemolytic. This is just kind of a trivia thing. But definitely alpha and beta hemolysis to know. The next one that I want y'all to really pay attention to is catalase. What catalase is it's an enzyme that breaks down the H2O2 and peroxide that is formed in the lysosomes of cells. And so this is actually a key virulence factor for certain organisms because it basically means they can't be destroyed by your macrophages and neutrophils without kind of having to pull in the bleach, which requires further signaling cascades and like permission from the T cells, which we're not necessarily going to get into. But when it comes to classification of your bacteria, catalase I want you to keep as the distinguishing factor between staph and strep. Streptococci do not have catalase. They are incapable of breaking down H2O2, whereas Staphylococcus can. Now, mind you, there are plenty of other organisms that are catalase positive. Pseudomonas, Nocardia, tuberculosis, aspergillus, they all have this functionality, but I have put them in kind of a gray color here because you're really not going to be asked about this. This is one of those things where it's just kind of like, technically this is true, but it really doesn't matter. So I've listed them here for your reference, but really I want you to keep it as staph versus strep. Coagulase is another important one. So at this point, we've distinguished staph from strep. When we get to coagulase, what we're trying to say is it Staph aureus or is it coag-negative staph? Typically Staph epidermidis. However, there are other variants of staph that fall into this category. So we use the term coag-negative staph or cons interchangeably with epidermidis. The purpose of coagulase is to actually cause clumping of the red blood cells. It actually is, again, a virulence factor for the Staphylococci, which kind of allows it to move through your bloodstream easier. So what'll happen is whenever you put this organism inside the culture medium in a coagulase positive organism, you'll get this clumping effect. See how kind of coagulated and stiff it is, versus a coag negative staph isn't going to cause that clumping. This is really important whenever you're doing blood cultures to make sure you have a Staph aureus infection versus like a Staph epidermidis infection. And so that's typically what you're going to see it used for. These other three are really not that high yield, but I've listed them here just for your reference. Urease is an enzyme that you typically see in H. pylori and Proteus. It hydrolyzes urea into ammonium carbonate and it actually leads to their disease processes. Lactose fermenting is typically going to be distinguishing E. coli from other gram-negative rods. However, some of the Enterobacter, Klebsiella, those also are lactose fermenting. But again, that's kind of one of those trivia things that I don't think you're going to use very often. So now that we've kind of talked about some of the classification styles, I really wanted to kind of draw your attention to this chart, which really is kind of the gist of what you're going to see. The shape of the bacterium is very important. Cocci being the most predominant ones when we're talking about gram-positives, and rods being less common. And then every now and again, you see branching filamentous gram-positive organisms. These are going to be your Nocardia and Actinomyces, rather low-yield organisms, but the branching pattern is very similar to fungus. And so they have kind of a unique pathology style, and I'll talk more about those when you get to organ systems. As far as the gram-positive rods go, Listeria and Bacillus are the main ones to keep in mind, as well as Clostridium. And you further break these down based off of whether they're aerobic or anaerobic. Okay, but let's use cocci as the prime example. These are just basically spheres, and so this is where we get that catalase negative and catalase positive breakdown. Catalase positive being Staphylococcus, catalase negative being Streptococcus. Their names kind of refer to the patterns that they form. So Streptococcus being a line of cocci, and Staphylococcus being a cluster of cocci. And then the Streptococcus, it breaks down into the partial hemolysis, the complete hemolysis, the no hemolysis, the alpha, beta, gamma hemolysis, which then breaks down into their individual bacteria. And when we look at Staphylococcus, again, you see the coagulase and coagulase between Staph aureus and the coag-negative staph. The bacitracin and novobiacin stuff pops up, but again, not overly important. I just wanted to point out that this process is not that complicated and that there aren't too many things to keep in mind. On the gram-negative side of things, it gets a little bit more complicated. It's kind of the opposite from gram-positive in that the cocci actually make a relatively small portion of the group, with diplococci being basically your Neisseria. So, for example, gonorrhea and meningococcus. And then you have coccobacilli, which are kind of a combination between the two. H. flu, pertussis, brucella, tularensis, all of these kind of pop up in here. But the gram-negative rods or bacilli are going to be the heavy hitters when it comes to gram-negatives. This includes your Pseudomonas, your E. coli, Klebsiella, as well as your Salmonella and Shigella species. Really, again, the key distinguishing factor is going to be that lactose fermentation. Yes, you get to the E. colis and Klebsiellas, Serratia, Citrobacter, and Enterobacter, not overly high yield, but again, they pop up, versus the non-lactose fermentings. This is where oxidase pops in, oxidase positive being predominantly associated with Pseudomonas. And then you get to the Salmonella and Yersinia and Shigella, the GI bugs per se. I don't want y'all to necessarily memorize this table. I just kind of want to give you a visual representation. Okay. Last thing here on growth medium, I've only included this slide because, again, it pops up every now and again, but I really would not put a lot of effort into memorizing this. If you are going to pay attention to it, maybe focus on Haemophilus, which is on chocolate agar fortified with factor 10 and 5, and Tyre Martin, which is associated with Neisseria gonorrhea. This being said, with the recent advent of PCR and DNA assays, this stuff is not done anymore. It just takes too long. It isn't very useful. So this is phasing out, and I don't expect it to really be testable for much longer because we just don't do this in the real world. Okay. This is a very brief overview of virulence factors. There are a lot of virulence factors, and you'll focus more on them when you get to the specific bacteria, but I kind of wanted to just provide a couple of examples. So there, you can kind of clump all of these into a couple of categories, but colonization and avoidance of immune system make up the major virulence factors. When we're talking about colonization, we're referring to things that basically allow them to adhere to a surface. The key example would be P. lion E. coli. This is what allows them to climb up the urethra to get into the bladder, for example, to cause urinary tract infections. Another key example would be biofilm formations and things like Staph epidermidis. This is why they're such a problem whenever you have any kind of artificial hip or artificial bone. If you get a Staph epidermidis infection in there, you basically have to take the whole thing out because it's just impossible to get anything into the biofilm. And it also basically protects them from antibiotics. When we talk about avoidance of immune system, this is going to be the vast majority of your virulence factors. The most obvious one being the presence of a capsule. This is an extra layer surrounding the cell wall that basically acts as a deterrent to antibodies, as well as an opsonization deterrent. So typically, whenever our macrophages come in, they try to eat the bacteria and then destroy it internally. The capsule pretty much makes them invisible to these phagocytes, so they can't be eaten and destroyed. The key players here are going to be your Klebsiellas. Strep pneumo is capsulated, as well as Haemophilus influenza type B, and some variants of E. coli and Neisseria. There are also some that have specialized proteins that kind of allow them to evade the immune system. The prototypical examples being M protein and strep pyogenes. This is actually what allows rheumatic heart disease to occur because it actually acts like a molecular mimic. The M protein allows the strep pyogenes to look like your own cells, so it could avoid the immune system, but in the process, it also encourages immunity formation against the actual body, which is how you get things like rheumatic disease. Again, you'll talk about these much more in detail later. I'm just introducing these topics. And protein A is similar to M protein and Staph aureus. Not a very high yield protein, but it's in the sketchy, so here it is. Type 3 secretion systems are often described as kind of like an injection hypodermic needle that can be used by the bacteria to inject their toxins into hosts. A lot of the GI bugs engage in this system, particularly E. coli, Salmonella, and Yersinia. Chlamydia and Pseudomonas also take advantage of them, but you're usually going to hear them in the context of these three: Yersinia, Salmonella, and E. coli. Okay, so talking about virulence factors, we then should talk about exotoxins. So an exotoxin, by virtue of the name, is saying a toxin that is excreted from the bacteria, exo being outside. And so usually these toxins require some kind of event where the bacteria gained a new gene. This can be in the form of a plasmid or a bacteriophage, which we'll talk about in a moment. And they kind of do a lot of different things. Again, this is not an exhaustive list, but I just wanted to give some examples. Shiga toxin, diphtheria toxin, tetanospasm, botulinum toxin. Basically, all the toxins you can think of that cause issues are going to probably be exotoxins. Superantigens that we think of also fall into this category. So these are going to be toxins that produce an extreme host immune response. What happens is they activate a T cell or a macrophage so hard that they just release a ton of cytokines trying to pull every immune cell into play. And what happens is this then leads to shock and low blood pressure, and your vessels become hyper permeable, and so you basically just like lose all the fluid in your body and you die from organ failure. It's really, really bad, really bad. Staph and strep are going to be your key players here with the toxic shock syndrome in staph, as well as exotoxin A, which causes scarlet fever in strep. These are big deals. So we really got to watch out for these. And then AB toxins are another subtype of exotoxins. The prototype examples are going to be cholera and pertussis. What happens is you have two units on this toxin. The A unit is the active unit, which is helpful because it starts with an A. And the B unit is the binding unit, also helpful because it starts with a B. So the B unit binds to the host, it induces endocytosis, and then the A unit does the actual toxic mechanism. And this is present in gram positive and gram negative bacteria. Endotoxins. So if exotoxins were on the outside of a bacteria, endotoxins are on the inside of a bacteria. And the key endotoxin to think of is lipopolysaccharide, which we mentioned earlier as being a component of the gram negative cell wall, outer membrane. The important thing to keep in mind when it comes to endotoxin is it only is released when the cell dies. So this is a problem whenever we're treating certain bacteria because you've now killed the bacteria, and in the process it's lysed, and now it's released all this lipopolysaccharide into your bloodstream, and it essentially acts as a super antigen, which we talked about previously, which then leads to a cytokine storm, fever, inflammation, vasodilation, shock, and ultimately death. So endotoxin is pretty bad. The bacteria that we need to worry about here are going to be your E. coli, your Pseudomonas, really any gram-negative in particular. So it makes treating gram-negative bacteria that much more complicated because you always have to be worried about this potentially being a side effect. Okay, I am going to very briefly cover the bacterial genetics. It's much more complicated. It looks much more complicated than it really is, to be completely honest. So I'm going to try to give a very simple overview of it. It should be enough to get you through the test this week, and will probably also be enough to kind of get you through STEP. So really, there's kind of three things to keep in mind when it comes to bacterial genetics. There's plasmids, transposons, and bacteriophages. Plasmids are extrachromosomal genes. They form a circular structure outside of the main chromosome, and they replicate independently of said chromosome. They are not necessary for any kind of um, uh, activities of daily living when it comes to the bacteria. You can take the plasmid away from it, and it will not change its life cycle. The plasmids, however, give bacteria new features. A lot of times, this is where they get their drug resistance from, is through a plasmid. And so long as plasmids have different origins of replication, they can have as many plasmids as they want. Transposons, on the other hand, are features of the bacterial chromosome itself, or the plasmid. Basically, what happens is you have segments of repeats that are recognized by enzymes that are able to kind of pull the transposon out and then just place it randomly somewhere else. So really, what we call these hopping genes every now and again, but it just kind of randomly will place itself in places. And this can be good, this can be bad. Again, this is a key component of multi-drug resistance. Knowing beyond this is above your pay grade. So just keep the basic concept. And then bacteriophages are viruses that particularly target bacteria. Bacteriophage means eater of bacteria. And so there's just a virus that infects a bacteria. Every now and again, the virus messes up, and instead of putting viral DNA or RNA into its capsid and infecting a new bacteria, it accidentally takes bacteria DNA. And so now you've reintroduced bacteria DNA into a new bacteria, which can then take advantage of that DNA to learn new tricks. Okay, so transformation is going to be kind of the first basic form of horizontal gene transfer when it comes to bacteria. All this is say a bacteria dies and it lyses, and all of its bacterial component, all of its genetic components are just going to get released into the environment. Another bacteria can kind of come along and see this piece of bacterial DNA, endocytose it, and so long as it has homologous recombination and competence, meaning that it basically has the mechanisms to deal with it, it can incorporate it into its genome. Really, it's very simple. Don't focus more complex than this. It's really just bacteria are taking genetic material from the environment that was released from a dead bacterium, and it needs homologous recombination and competence to be able to use it. Conjugation, on the other hand, is probably much more scarier of a concept to kind of look into, but really it's actually pretty simple. I think of this as horizontal transfer of DNA directly between bacteria, essentially bacterial sex. It's not a one-to-one correlation, but it's pretty similar, particularly when you take into account the sex pilus. However, the basic way to think of conjugation is the F plus F minus form of conjugation. Pretty much all this means is one bacteria has a plasmid, in this case the F plasmid, and another one does not. The F positive plasmid is able to transfer a copy of said plasmid to the F minus cell. Through the sex pilus, it allows joining and acts as a kind of pathway for this replication to occur. The bacteria replicates itself, and both end up being F positive when all is said and done. That's the important thing to keep in mind. Versus the HFR F minus form of conjugation, HFR meaning high frequency of replication, and F minus again meaning it doesn't have the F plasmid. or the F factor in this situation. The way this one differs, however, is the HFR cell also does not have an F plasmid. There's a step that's missing here. Really, what's happened is this plasmid has incorporated itself into the bacterial genome for whatever reason, beyond the scope of what you need to know. But as you can see, the F factor, the F positive plasmid, as it would be in this other situation, is now within the actual genome. And so what happens is whenever this conjugation occurs, this is replicated and sent over to the other cell. However, along with it comes some of these extraneous pieces of the genome as well. So it's not just the F plasmid, it also sends over some of the surrounding bits as well. And of note, it does not form a plasmid. It, again, just kind of has free-floating DNA, which may or may not incorporate into the F minus cell. But the reason it stays F minus is there was no plasmid to send over, so no new plasmid is developed. Again, these feel more complicated than they actually are. Just kind of pay attention to these charts a couple times and it should be pretty straightforward. I really wouldn't stress too much about this. Transduction is really just another form of virus-mediated horizontal transfer. So there's kind of two flavors of this. There's generalized transduction and specialized transduction. In generalized transduction, it's just like a normal virus infection. So bacteriophage comes, it infects the bacterial cell, its DNA has now entered it, it replicates itself, but accidentally, some of the bacterial DNA in the process of lysing the cell got put in a capsid. Now that virus is still able to target a host and send whatever it's holding inside of it, except now it's not viral DNA or RNA or whatever this situation is. Now it's bacterial DNA, which can then, through homologous recombination, much like in transformation, incorporate it into the genome. And now this bacteria has gained new genes. In specialized transduction, it's a bit more complicated. What this requires is some form of lysogenic or temperate phage. All this means is rather than killing the cell, the virus incorporates into the host DNA, very similar to like HIV or adenovirus or any of the other viruses that incorporate into DNA. So much like in this situation, the bacteriophage incorporates into the DNA, and when it comes time to finally leave and infect new cells, sometimes it makes some mistakes and clips some of the surrounding genes from the bacterial DNA. And so what you see here is a situation where you have bacterial DNA in the red, but there's actually host DNA as well that's kind of tagged along with it. And so anytime this bacteria goes to infect a new host, it brings along with it some new bacterial DNA, which can then incorporate into a new host, and that host has now developed a new gene. All right. And really that's it when it comes to the bacterial genetic stuff. It feels much more complicated, but it really is that simple. I would just focus on like those 3 slides and make sure you really understand those concepts, because most of the questions you get aren't going to be much more complicated than that. It's a conceptual thing, not necessarily, you don't need to, write a thesis on it. Okay. So moving on from the basics of bacteriology to antimicrobials, this is going to be the brunt of this test, as well as STEP, and pretty much a lot of your microbial medicine moving forward. This is the meat of what infectious disease does. There's a bacteria that has infected someone. How do we stop it? So the first class of drugs that we typically think of when we think of antimicrobials is going to be the drugs that target the outer membranes or the cell wall of the bacteria. So you can have drugs that target the cell wall itself. These are going to be all your beta-lactams, as well as glycopeptides like vancomycin. There are some antibiotics that will target the cell membrane, like daptomycin, and there are some that will target the outer cell membrane of gram-negatives, like polymyxins. And we're going to start with these. And mind you, all of these are bactericidal, because once you have removed the outer layer of the bacterium, you've essentially lysed it. And so all the internal components are going to leach out into the environment, and that bacteria is dead. So beta-lactams are going to be your heavy hitters when it comes to the typical antibiotics that we think of when we are targeting most bacteria. This is going to be the old school drug that we use, and kind of the all-around heavy hitter. So penicillin is the prototype beta-lactam, but all of these other ones are derived from penicillin and incorporate this beta-lactam ring. So cephalosporins, monobactams, carbapenems, they all have this basic structure, and then everything else is just there to kind of give them better resistance against bacterial resistance. So the beta-lactam itself actually mimics the D-alanine residues of bacterial peptidoglycan. So in the cell wall of gram-positive organisms, they have this peptidoglycan, and it needs to be cross-linked to actually be stable. And so there's a protein called the transpeptidase subunit, or the PBP, that basically comes in and it does this cross-linking between these alanine residues. Penicillin, on the other hand, blocks it by being a competitive inhibitor irreversibly, and basically pulls it aside, like over here. So now these remain unlinked. The cell wall is weak, and eventually it just degrades and the bacteria dies. So that's kind of the basic function of penicillin. Now, as we mentioned, this is bactericidal. The cell cannot live without its cell wall, and so it dies. The key kind of side effects to keep in mind when it comes to penicillin are going to be the typical IgE-mediated hypersensitivity. So this is your anaphylaxis, your stomach upset, hives, itchiness, the things you typically associate with allergies. Another really big side effect is going to be acute interstitial nephritis. This is basically like an allergy in the kidney. You'll talk way more about this when you get to renal second year, but the penicillins are really bad about causing acute interstitial nephritis. And then when it comes to resistance, what happens is the bacteria produce enzymes called beta-lactamases that basically cleave this beta-lactam ring. It is now no longer functional. It can't target the transpeptidase, and it's lost its function. Okay, so penicillins. There's a lot going on in this slide, but I really wanted to kind of hit some of the key points when it comes to penicillin. So old school generic penicillin made by Alexander Fleming back in the early 20th century is going to mostly just be used for typical gram-positive organisms. And when I say gram-positive, I mostly mean Streptococcus. You can essentially not use penicillin for staph because it, one, won't even work for methicillin-sensitive staph. It definitely won't work for methicillin-resistant staph. More on that in a moment. The other bug that you're going to target with penicillin is syphilis. There's several other things that you can use penicillin, just regular penicillin with, like actinomyces and Pasteurella, but these two are going to be the ones you typically answer questions on. Bioavailability, oral versus IV, isn't super important at the level of step 1, but if you're interested in those kind of things, this information's here. But what do we use penicillin for? Well, obviously we use it to treat bacterial infections. The mainstay that we're going to use it for is strep throat, strep pyogenes. To date, there is no resistance that has been documented in strep pyogenes to penicillin, which is why your kid can get signs and symptoms of a strep throat. You take them to the pediatrician and they give them some amoxicillin or penicillin and send them away. They get better, and we have no rates of all the bad side effects that come from strep infections, like rheumatic heart disease and stuff like that. If this changes, we'll be in trouble, but for now, we're going to keep treating strep throat with penicillin. Some of the other strep species you can treat with penicillin, such as strep viridans and bovis endocarditis. This is an infection of the valves of the heart. You'll talk more about that in cardiology, and is also used as a prophylactic agent for moms that are colonized with group B strep or strep agalactiae during pregnancy. This can cross the placenta and cause really bad sepsis in newborns. So we definitely don't want this to go untreated in those moms. As we mentioned before, Ig hypersensitivity and acute interstitial nephritis are the main issues associated with side effects. Okay, so nafcillin and oxacillin. These are called the staph penicillins. You can usually remember this as NAF for staph. We don't really use these much anymore because of methicillin resistant Staph aureus or MRSA. But in the days prior to that, this used to work. So these penicillins, their structure gives them inherent beta-lactamase resistance, which would be great. Unfortunately, Staph aureus has developed its own form of resistance, where it actually changes the protein itself. Now is no longer able to be bound by the penicillin. Rather than destroying the penicillin like a beta-lactamase, it just straight up changes the enzyme. So big problem. Don't really get to use these anymore. If you know it is methicillin sensitive Staph aureus, you can use these. However, we're still probably not going to use them because nafcillin actually burns whenever you give it IV. So it's not a really great drug to give. Most people don't like to get it, and you can pretty much treat MSSA with other stuff. But old school, naf for staph. And then we get to the aminopenicillins. These are basically penicillins that got some amino groups thrown onto them, and now they're able to attack gram negatives. They do still hit gram positives, though, and that's important because we kind of use amoxicillin and ampicillin interchangeably with penicillin, but they also give the gram negative coverage. There is a mnemonic for it. I don't like using these mnemonics, but I listed it here just for your benefit. Really, the stuff that's getting hit here are going to be upper respiratory infections, some GI stuff, and then a couple of more gram positives, Listeria and Enterococcus being gram positives. But really, it's like H flu causes otitis media, sinusitis, upper respiratory infection type stuff. H. pylori causes stomach ulcers. E. coli, we all know that one. Shigella, salmonella, GI stuff. And then Proteus is a UTI bug. The amoxicillin versus ampicillin split. Not super important for step 1, but when you get to step 2 and kind of just clinical medicine in general, amoxicillin is given orally. You can give it as a pill or a tablet. Ampicillin is given IV. So if you're in the hospital, you get AMP. If you're sending someone, medicines at their pharmacy, it's amoxil. Okay. There are also combo aminopenicillins where they come with a beta-lactamase inhibitor. So these are things like sulbactam, tazobactam, clavulanate. They do not have any bactericidal activity of their own. They just block the beta-lactamase activity. And so these are things like Unicin, Zosyn, Augmentin, Timentin. At this stage, not super important to know like why these are used for different things. In short, Unicin is good for anaerobes. Zosyn is good for Pseudomonas. And then Augmentin is just, if you are using amoxicillin for any of these and it doesn't work, try giving them clavulanate and see if it works. That's the gist of it. I've never seen Timentin used, but it exists. As we said, sinusitis, otitis media, and upper respiratory infections are going to be the mainstay for amoxicillin treatment. And then Pseudomonas can theoretically be treated with Zosyn, which is piperacillin and tazobactam. You'll see a lot of the surgeons like to use Zosyn for this reason. We'll get to more on Pseudomonas drugs, but this is one of those that can treat Pseudomonas. And then the same side effects as penicillin. Okay, cephalosporins. Cephalosporins feel very overwhelming, and they are overwhelming. And the first thing I'm going to say about this slide is do not memorize everything on this slide. It's very busy. There's a lot of information here, and to be completely honest with it, most of it is bullcrap. So, as I'm sure you're aware, there are several generations of cephalosporins. I want to say we're actually to generation 6 now, but don't worry about that. Each generation basically becomes more gram-negative focused. So Gen 1 is almost mostly gram-positive, a little bit of gram-negative. You can kind of equate it to the aminopenicillins. However, the aminopenicillins actually have better coverage. And then once you get to generation 2, you've added even more gram-negative coverage. By the time you've reached generation 3, you're essentially only doing gram-negative. You don't really actually have a lot of great gram-positive coverage by the time you've reached generation 3. Generation 4, I've used this rainbow coloring here again to kind of associate with the sketchy mnemonic with the kind of prism and the rainbow, because this is really used for broad spectrum antibiotic coverage. We use cefepime all the time in the hospital, and we'll talk about that in a moment. And then finally, generation 5 is we only really use it for methicillin-resistant Staph aureus, MRSA. It works, but we really don't like to use it because the more we use it, it's probably not going to start working for very long. Okay, so backtracking. Gen 1. As far as memorizing all of these antibiotics and which generation they go to, probably not worth your time. This will come with use, especially once you actually get to the clinics and you start seeing these drugs used more often. For now, I would just recognize the CE, F, Ceph beginnings to associate them with cephalosporins. If it has Ceph in the name, it's probably a cephalosporin. The ones I would say to focus on are ceftriaxone, ceftazidime, and cefepime. These are going to be the 3 that really pop up all over the place. Cefazolin, Cephalex, and all those things very rarely are going to be question fodder. But ceftriaxone is kind of good for just about anything. And ceftazidime is important because it has pseudomonal coverage. Always pay attention to the things that have pseudomonal coverage. Only so many things can tackle Pseudomonas, so they really love to ask questions about this. Okay, this SS-Pec, Hens-Pec, all that crap, don't memorize it. It's not useful. Just kind of know increasing gram-negative coverage. There's a lot of specific uses for things. Cefazolin has a very specific use in preparing for surgery. Really, it's just to prevent surgical site infections is really all it's used for. Every now and again, you can use it for basic infections. Generation 2 is very similar to aminopenicillins, but you're probably going to use aminopenicillin over one of these. And then generation 3 has a lot of uses, like I mentioned. It can treat pneumonia, it can treat meningitis, it can treat endocarditis, it treats gonorrhea. It is the drug of choice when treating gonorrhea, and it can treat Lyme disease. We don't really see that in Arkansas, but it does pop up on the boards. And then cefepime. The key here is cefepime is essentially ceftriaxone with Pseudomonas coverage. It's more complicated than that, but that's how I want you to think about it. So when you get to the hospitals next year and you're on your internal medicine rotation, you're going to see just about every single patient in the hospital with cefepime on them. And the reason for that is in part because we like to overprescribe some antibiotics. But what we're getting at is this Pseudomonas. If you have been in the hospital, it is assumed that you have exposure to Pseudomonas. So that oftentimes will get you bumped up to cefepime until we can roll it out. That's where you get these severe nosocomial infections as well as multi-drug resistance. And then, as we said, ceftaroline only can really use for MRSA. Don't use it otherwise. Okay, carbapenems and monobactams. I'm not going to spend a lot of time on these because these are like way top of the shelf antibiotics. Really, I just want you to associate carbapenems as the big guns. If nothing else is working, throw a carbapenem at it. There's some extra information in here, like cilastatin has to be used. Otherwise, imipenem will be broken down in the kidneys. We don't use imipenem because we don't want to give cilastatin with it. We use meropenem and ertapenem. Just pay attention to the penems. All of this is kind of really beyond what you need to know. They do have some pretty significant side effects, particularly in the GI upset region, and it can lower the seizure threshold. Aztreonam or amonobactam is the only drug in its class. It only treats gram-negatives, which is weird because it's a beta-lactam, but it also does treat Pseudomonas. The only thing we use aztreonam for is basically if you have a penicillin allergy, but you need to cover one of these gram-negatives or Pseudomonas. This is just kind of an option to get around that. Okay, so after we've discussed the beta-lactams, we get more to the glyco and lipopeptides. So these are going to be your vancomycin and daptomycin. Vancomycin getting its name from being the quote-unquote vanquisher of Staph aureus. It targets gram-positive organisms, and it functions differently from a beta-lactam antibiotic in that where beta-lactams targeted the transpeptidase enzyme itself, vancomycin binds the actual sugar peptide components of the peptidoglycan wall. So as you remember from earlier, Staph aureus developed resistance to penicillins by changing the D-aller residue to a D-lactate residue. So vancomycin actually binds this and blocks the enzyme from being able to come in and cross-link. As you can see, the vancomycin is so big that it just completely blocks the enzyme from coming in. They remain unlinked, and the cell wall degrades, much like in a beta-lactam. But it's able to overcome that MRSA mutation. So we use vancomycin really for MRSA and staph epidermidis. So you'll see almost everyone in the hospital on vancomycin because we just kind of assume MRSA is out there. You can also use vancomycin to treat enterococci so long as they are susceptible, which is key because there's a lot of vancomycin resistant enterococcus, or VRE, that we have to worry about. And then C. diff, you can actually give vancomycin orally. Now, mind you, this is an IV medication, but it doesn't go through the gut mucosa at all. It has no gut bioavailability, so you can give it orally, and it will clear out your colon of C. diff and not give you any systemic side effects. Key things here is nephrotoxicity. This is what the big kind of thing to worry about when it comes to vancomycin. That being said, we still give vancomycin pretty often, even in patients with severe renal failure. You just kind of have to be careful with it. But this is going to be the thing that gets you. Don't use these in really, really bad renal patients. It has some mild ototoxicity, doesn't pop up as much as the nephrotoxicity. And then red man syndrome is kind of another big thing to keep in mind. I've given a picture of red man syndrome over here, and I want to emphasize that it looks like an allergic reaction, but it is not one. So red man syndrome is actually a benign red discoloration of the body. It's kind of itchy and it looks scary, but if you turn down the titration and just kind of make it run a little bit slower, it usually goes away. So do not treat this like an allergy. These folks, this will happen, and then they never get vancomycin again because it gets called an allergy when really it's not. Daptomycin, on the other hand, is a lipopeptide. It actually targets the inner membrane of the bacterium, and because of that, it also kind of can target some of our membranes a little bit, which is why you get some of this rhabdomyolysis effect. But basically, you get this lipid tail that inserts into the membrane, and it creates a channel that allows ions to flow through and destabilize, and the cell dies. Daptomycin is great against MRSA, as well as the vancomycin-resistant enterococcus that I mentioned over here. Key thing to look out for is rhabdomyolysis. Check those CK levels. That's a sign of muscle damage. And then you can't use this for any pneumonia because the surfactant actually stops it from working. Polymyxin and phosphomycin are the last of the outer antibiotics. Polymyxin only works on gram-negatives. It targets the cell membranes and disrupts them. However, we also have cell membranes in our cells, so you can only give this topically. It's going to cause really bad reactions if you give it systemically, nephrotoxic, neurotoxic. So we give these on topical solutions, say for a skin infection or an eye infection, but otherwise we don't take these systemically. But it's really good for severe gram-negative organisms. And then phosphomycin, I've really not really heard much about this one, so it's here if you want to learn about it. Okay, so those are the outer boundary, external boundary antibiotics. Now let's talk about some of the antibiotics that target stuff on the inside of the cell. So the first thing we're going to talk about are things that target protein synthesis. I have a mnemonic here that actually I think is really good. It's not ideal because it has things in there that don't actually get involved with the mnemonic itself, which I think makes for a bad mnemonic, but it's pretty nice to remember these. So the mnemonic is by at 30, cell at 50, with cell spelled CELL. The AT references aminoglycosides and tetracyclines, which function at the 30S ribosome. And then the CELL refers to chloramphenicol, erythromycin, which is a macrolide, lincosamide, which is clindamycin, and linazolid. And these all function at the 50S ribosomal subunit. Most of these are going to be bacteriostatic. not necessarily killing the bacteria, but preventing it from growing further. There's a couple of exceptions. Okay, aminoglycosides are the first one we're going to talk about. I would hesitate to say focus on the mycin um, suffix because this kind of like appears in a lot of other antibiotics and it's not specific to aminoglycosides. So I would mostly just kind of like know the names: gentamicin, neomycin, amikacin, tobramycin, streptomycin. The more you see them, the more you're going to associate with them. There is this mnemonic mean gnats. Again, I don't love the mnemonic, but the mean and amino and then the GNATS. If it helps, it helps. But these, like I said, bind the 30S ribosomal subunit. This one is unique in that it is bactericidal. It will kill the cell. However, these only work in aerobes. You need oxygen for them to work. A lot of times they're given with penicillin or some penicillin antibiotic because it will destroy the cell wall and allow these to actually get into the bacteria to help kill it. So it has a synergistic effect. As we mentioned, aerobic gram negatives. Pseudomonas is covered by gentamicin and tobramycin. A lot of your CF kids at Children's will be on these, and it can treat vancomycin-resistant enterococcus. So we're really only going to use these for severe aerobic gram-negative bacilli, including Pseudomonas, as well as some bowel surgeries. There's some like niche uses of them, but I wouldn't focus too much on them. Resistance comes in the form of actually changing the enzymes themselves by acetylating, adenylating, and phosphorylating them. Key things to keep in mind here is the side effects. Most of the questions you get about aminoglycosides are going to be on the side effects. Nephrotoxicity and ototoxicity being the big things. And it actually has to do with the correlation of the peaks. I won't go too much into that right now, but we don't actually use these drugs all that often because of how much side effects there are. And then it's teratogenic, so you can't use it in pregnancy. Causes deafness in newborns. And it has some neuromuscular blockade, so you can't use it in myasthenia gravis. Okay. Tetracyclines are going to be the next drug we talk about. The prototype drug being doxycycline. These are also 30S ribosome subunit blockers, and these actually block the tRNA from entering the ribosome. I always remember these as tetracyclines start with a T. They block tRNA. Unlike aminoglycosides, they are bacteriostatic, meaning they do not kill the bacteria, but they prevent them from replicating. They are broad spectrum. You can use them for a variety of things, gram-positive and gram-negative. They accumulate intracellularly, however, which makes them very useful in targeting intracellular bacteria. And what do I mean by that? These are going to be all your tick-borne pathogens. So Borrelia, Anaplasma, or Ehrlichia. If it comes from a tick, you can probably use doxycycline. Rickettsia, also a tick-borne, but lives within the cells. Chlamydia lives within the cells. Doxycycline is actually part of the treatment for chlamydia and gonorrhea because it can target chlamydia. Mycoplasma, a lot of the atypical pathogens can be hit by doxycycline. MRSA can also be hit by doxycycline, as well as more specifically tigecycline. Tigecycline is a newer drug. It's very similar to ceftaroline in that we really only use it for really bad MRSA, but it has more or less the same mechanism of action. And then every now and again, if you have really bad acne, you can use doxycycline. And then there is a niche use of a dimeclocycline. It's not actually used for antibiotics anymore, but it can cause nephrogenic diabetes insipidus. So you can use that in SIADH. Those are a bunch of words that you're probably not going to know what I'm talking about right now. It will make sense later when you get to renal and endocrine. So keep this in mind. Resistance come in the form of TET mutations. These actually upregulate the drug efflux pumps that actually pump the drug out of the bacteria. The reason tigecycline is good is it's unaffected by these, but that also makes it not used very often because we don't want resistance to develop. Side effects come in the form of the fact that these bind cations, particularly calcium and magnesium, which can cause tooth discoloration as well as some bone mineralization problems. It also causes photosensitivity, so be careful giving these to folks going out to the beach or going to places where the sun's really rampant. So, for example, doxycycline can be used to treat malaria. However, you got to keep in mind a lot of these folks are going to places like the sub-Saharan Africa or South America where the sun is very bright. So you got to be careful of that photosensitivity. Like a lot of these antibiotics, they are teratogenic. So you cannot give these to pregnant women. And there is a contraindication to giving these to children. In the real world, this is not that big of a deal. In test world, you do not give doxycycline to anyone under the age of 8. And the reason for that has to do with this cation binding. It can cause some issues with bone growth. But like I said, test world, don't give it. Real world, we can work with it. Okay, chloramphenicol. This is a drug you will never use. It binds the 50S ribosome subunit, blocks the peptidyltransferase component of the ribosome, like many of the other ones that is bacteriostatic. It is broad spectrum. However, we don't use it because it has a lot of bad side effects. As here, not used in the United States. The situation you're going to see chloramphenicol pop up is someone that is vacationing in Mexico, gets some kind of illness, goes to the hospital there, and they get chloramphenicol. The reason we don't give it is it can cause aplastic anemia. What this means is it pretty much destroys your bone marrow for a given amount of time. You can't produce new blood cells. You can't produce new lymphocytes. It's really bad. Tack this on in a newborn who lacks the UDP glucuronidyltransferase, and they develop something called gray baby syndrome. This is the reason we don't use it in the United States, because this kills babies. It puts them into cyanosis and shock because of the severe aplastic anemia, and they die. So we don't use these in the real world, but in the United States, but you will see them in developing countries. Okay, macrolides are another really big group of medications. Erythromycin is kind of the prototype, but we only really use azithromycin. They bind the 50S subunit, and they are bacteriostatic. They block the actual movement of the ribosome. There is a mnemonic macro slides. They block the sliding effect of the ribosome. Like a lot of these, they're broad spectrum, can be used for gram-negative and gram-positives. They're really good for atypical bacteria. And when I say atypical bacteria, that's what I'm talking about. No cell wall or weird cell walls to the mycoplasmas, the Legionellas, the chlamydophilus, a lot of those pneumonias that don't have the typical presentation. These will make a bit more sense a year from now when you take the POEM module. You can also use these for chlamydia and gonorrhea, especially in situations where ceftriaxone resistance or doxycycline resistance exists. You can use azithromycin to kind of help with that. Pertussis, as well as Mycobacterium avium complex. This is a form of Mycobacterium similar to TB that only infects immunocompromised individuals, particularly fulminant AIDS patients. You're not really going to see this outside of an AIDS patient. Every now and again, you can use it in the situation of penicillin allergies for strep. And there's a not off-label, but off-antibiotic use in gastroparesis. And the reason for that is it causes gut motility issues. So this is a side effect, but also can be a therapeutic thing if your gut's not moving. The real issue, though, is QTC prolongation. What this means is the gap in your heart rates gets longer, and so arrhythmias can develop. So anyone that already has an arrhythmia or has other drugs that cause QTC prolongation, this is a big problem. And there's several other antibiotics that do that. These other things are not that big of a deal, but they do cause P450 inhibition. Azithromycin does not do that, which is part of why we use azithromycin and not erythromycin. So lancosamides are going to be next. The prototype here is clindamycin. So this also binds the 50S ribosome subunit, blocks peptidyltransferase, has a very similar mechanism of action to chloramphenicol. As many of the other ones, is bacteriostatic, broad spectrum. But what I want you to think of when you think of clindamycin is anaerobe coverage. So these are going to be things that cause your abscesses, anything where an abscess is a concern. As far as like memorizing anaerobes, it's really not that important. You'll start to associate which things are anaerobes, Clostridium being kind of one of the prototypical ones to keep in mind. But it also works against MRSA. So the common mnemonic is anaerobes above the diaphragm when referencing clindamycin. So aspiration pneumonias, abscesses, as we mentioned, and the Bacteroides clostridium infections. There is another drug that we'll use for quote unquote anaerobes below the diaphragm. However, this isn't a hard and fast rule, and we'll get to that later. Resistance is by methylation. The issue with clindamycin is it is the worst drug that leads to C. diff overgrowth. Really, any antibiotic can cause C. diff overgrowth, but clindamycin is the worst. It also causes GI upset and just tastes bad, particularly in the oral solutions for kids, which is very interesting to me because the doctors over at Children's use it all the time, even though apparently it tastes horrible, which seems like a problem for kids, but what do I know? Oxazolidinones, otherwise known as linezolid. These are relatively newer drugs. They also block the 50S ribosome subunit, or bacteriostatic. They actually block initiation of the ribosome subunit. Unlike the other ones, which are broad spectrum or gram-negative, this one is actually gram-positive only. Mostly it's used for MRSA and vancomycin-resistant enterococcus. What's nice about these is you can give them orally. So it's great for folks that have been in the hospital on vancomycin or something, and now you need to finish treating them. You can send them home on linezolid. However, that being said, you cannot use linezolid for bacteremia for a couple of reasons. One, linezolid, for whatever reason, just really doesn't penetrate the blood very well. So if you have bacteria in the blood, you don't really want to use a drug that's not going to reach them. The other thing is, because it's bacteriostatic, once stuff has made it to the blood, that's a pretty big problem. You want to kill anything that's there. So bacteriostatic drugs you really shouldn't be using for bacteremia. Like a lot of the other ones, it can be methylated, usually has cross resistance with macrolides, not super important. Main issues here is serotonin syndrome. It has mild monoamine oxidase inhibition. You'll learn more about that in Brain and Behavior. But basically what happens is it increases your base level of serotonin, and too much serotonin can cause you to feel sick, GI upset, tremulous, anxious, basically just like really worked up. Also can do some mild myelosuppression, but the big thing is it's expensive, which is unfortunate because you get a lot of these folks that have been in the hospital, so their bills are already going to be really high, and now you're sending them home with a drug that's like $50 a pill. But it treats MRSA. Okay, so those are the translation blockers. Now we're going to talk about the replication and DNA blockers. So fluoroquinolones, these you will know as the floxacins, so ciprofloxacin, moxifloxacin, and levofloxacin. These are DNA gyrase and topoisomerase inhibitors. So DNA gyrase is an enzyme in the bacteria that prevents the supercoiling during replication. So if you block this, all of their DNA gets tightly wound up together. It can't replicate and it dies. So bactericidal. These are broad spectrum, and they cover Pseudomonas if they are respiratory quinolones. So moxifloxacin and levofloxacin are respiratory quinolones. They're called that because they block Pseudomonas. It has actually nothing to do with whether or not they penetrate the lungs or not. Cipro can still hit it, but Cipro can't hit Pseudomonas. That's just a naming convention. These are used for really severe infections. So hospital-acquired and atypical pneumonias, especially if you're concerned about Pseudomonas, as well as bad UTIs and anything that reaches the kidneys, pyelonephritis. Some GI infections, as well as these are nice because you can switch people from the IV to the PO, because most of these have IV and PO forms, ciprofloxacin having a PO form. If you mutate the gyrase, the antibiotic doesn't work. Problem with these, they're great drugs, but they have a lot of side effects. Big things are going to be basically collagen issues. So Achilles tendon ruptures, particularly in the elderly population, as well as cartilage damage in the younger population. So you have two bimodal peaks of people that you shouldn't use these drugs in, which is a problem. The other thing is it causes really bad QTC prolongation. So as we mentioned before with the macrolides, you get an increased risk of heart arrhythmias and death. So that you can't use these in combination with other QTC prolonging drugs or folks who have an underlying arrhythmia. There is some new evidence to suggest that it has increased risk of aortic dissection. I don't know that this is going to be on the NBMEs and STEP just yet, but this is coming, and they inhibit the P450 system. So lots of side effects, lots of contraindications. You don't give these to children, and you don't give these to the elderly if you can avoid it. Now, obviously, these are great drugs that are useful in certain situations, so you have to use your clinical judgment. But in general, especially on the boards, avoid these two populations. Also, you can't use these in pregnancy. Okay, sulfamethoxazole trimethoprim. And in fact, this is kind of just sulfa drugs in general, which is why you have sulfamethoxazole SMX and dapsone. Dapsone has a very similar mechanism of action. So sulfonamides and trimethoprim. Sulfonamides block the first portion of the folate acid cycle. The dihydrooctanoate synthase blocks folate. By itself, it is bacteriostatic. Trimethoprim, when given in combination with sulfonamides, blocks the next step of folate production. And now, together, they are bactericidal. Individually, they are bacteriostatic, which is why you give them together. These are broad spectrum, bactericidal together, and they do cover MRSA. So these are actually great drugs to give orally because they do have oral components, and they're really good for treating a lot of things, particularly UTIs and pneumonias. UTIs, and it can be used to treat several AIDS-defining illnesses, such as PCP pneumonia or pneumocystis jirovecii. This is an AIDS-defining illness that affects typically only folks that have really low CD4 counts. You give this drug to them prophylactically to prevent this as well as to treat it. It also prevents toxoplasmosis in AIDS, and dapsone, which is a sulfa drug, can be used to treat leprosy. Big things here are hemolytic anemia. As you probably learned in the molecules to cells course, these can activate a reactive oxygen species formation in folks that have that G6PD deficiency, and so they can get really bad anemia really fast if you give them to these. These also are really bad about causing Stevens-Johnson syndrome. So these folks will have allergies to sulfa drugs, and you need to take those seriously because they have pretty bad effects. Sulfa drugs also displace proteins from albumin. So in babies, it can cause kernicterus because it knocks off some of the bilirubin that is in your blood, and it goes to your brain and it causes brain damage. So you can't give these to infants or women who are pregnant. Also, it causes neural tube defects, so it's teratogenic anyway. So great drugs, lots of side effects. And then there's metronidazole. This basically just causes free radical formation and deals DNA damage. It's bactericidal, kills the cells. You use this actually for anaerobes in the gut and protozoa. So anaerobes below the diaphragm can also be used for vaginosis, which is a bacterial infection of the vaginal flora, or rather an overgrowth of normal flora, which causes pH imbalance and just general unpleasantness. And then all of your anaerobes, including C. diff. However, it's also used to treat protozoal infections. This is Giardia, Entamoeba, Trichomonas. This is an STI. I've given you a picture of Giardia, and these are kind of like free-living amoebae and protozoa that kind of live in your gut and can cause really bad diarrhea illnesses. Side effects with metronidazole is this disulfiram-like reaction. You'll learn more about this in brain and behavior, but disulfiram actually induces the hangover-like symptoms. It's a way to get people to stop drinking alcohol. We don't actually know why metronidazole does this, but it kind of makes you feel hungover. So you can imagine folks who take this and then drink alcohol are going to feel very unpleasant. Other things associated with it is this metallic taste, as well as general GI upset, nausea, vomiting, constipation. A general rule of thumb, if you don't know what a side effect of an antibiotic medication is, you can probably guess GI upset and be correct. Okay, so those are all the bacterial antibiotics. I went through those really fast. Take some time to look back over those slides. There's a lot of key points that I tried to bold. A lot of the step relevant stuff is is bolded. But they really aren't that bad, especially once you get used to using and thinking about them. It'll get much better once you get into your clinical rotations and you actually start seeing some of these drugs used in the clinical setting. Okay, but now let's talk about viruses. And we're going to go very briefly over this because viruses are very complex organisms and we don't really have time to go into them in too much detail. Okay, in their most basic sense, a virus is a non-living amalgam of protein and nucleic acid. They have no organelles. They have nothing that we associate with living creatures. They are just obligate intracellular rogue proteins and nucleic acids. And their only purpose is to replicate, and they'll do all the damage they can in the process. There's several ways to classify it. It's beyond the scope of what you need to know going into medicine. There's a whole Baltimore classification system based off of whether they're RNA and DNA and how they replicate, but beyond the scope of what you need to know. I just wanted to show it here in case you were curious. The other kind of key elements are the type of capsid. Is it icosahedral, which is the more typical, or is it helical, which there's not an example on here? And then is the virus naked and that it has no envelope, or does it have an envelope? And these are key to kind of defining what the viruses themselves do. So first we're going to talk about the capsid. So you have either the icosahedral or the helical capsid. This is your 20-sided shape, can be naked or enveloped. Examples include parvo, herpes, noro. Helical viruses, on the other hand, must be enveloped. And the reason for that is this helical formation has no structural stability whatsoever, so it needs some kind of envelope to keep it from just becoming a coiled mess. These are going to be a lot of your more fluid or bloodborne viruses, such as HIV, Ebola, and influenza. Now let's talk about envelopes. So you have your naked and your enveloped proteins, or viruses. So naked is just the protein capsid. And it feels odd that this is the case, but these are actually more stable in the environment than those that are enveloped. And the reason for that is there's no lipid layer that is exposed to the environment. So they're immune to desiccation, acid, heat, detergents, so on and so forth. So these are going to be your fecal oral route viruses, the kind that they typically infect your gut. They cause diarrhea illnesses. That diarrhea, some of the particles will get on your hands. You touch something, now you've spread it to that surface, and they stay on that surface for days to weeks. And the next time someone comes over and touches that surface, those microscopic fecal particles will get on their hands. They eat food, and now they have inoculated themselves with this virus. That's what we mean by fecal oral. It's not that people are going over and eating feces. So when talking about enveloped viruses, the thing to keep in mind here is that unlike the naked viruses, which are environmentally stable, enveloped viruses typically are environmentally labile, meaning they're very vulnerable to desiccation, acid, heat, detergents. These viruses require some form of protective medium. So you're usually going to find these viruses in, say, blood or semen, respiratory droplets, some kind of fluid transfer that's between person to person. Once they kind of get exposed to the air or the environment, they typically degrade pretty quickly within the matter of seconds to minutes, which is very different from the naked viruses, which degrade within days to weeks. So these can still be very, very infectious. It's just they require much more person-to-person contact. And that's just by virtue of having that lipid bilayer, which is much more environmentally unstable. Some notable examples being HIV, herpes, the flu, Ebola would be in this group, and really any of the helical viruses in that sense. So the way viruses work is every single virus has a specific host that it targets. That's called viral tropism. Every virus has a specific cell that it infects. It's designed to infect that cell, and the disease process you see is a result of that of that cell's infection. The virus goes in, it takes over the intracellular machinery, and that effectively kills the cell or makes it non-functional. It can't serve its normal role as a cell in your body, and you get pathology because of it. So the way that the viruses target these cells is through binding proteins, usually on the capsid or the envelope itself. These binding proteins will bind a specific protein on the surface of a host cell that both allows it to be seen by the virus and targeted by the virus, but there will usually also be some kind of protein on the surface of the virus that engages in fusion or induces endocytosis, um, as mentioned here. So using HIV as an example, GP120 on the surface of HIV binds CD4 on the surface of T cells. So you have your HIV molecule. It's coming through. It finds a CD4 T cell. So here's CD4. And it also requires CCR5 as a co-receptor. The CD4 binds to GP120, comes in. Now the virus is connected to the host and it's able to fuse through. And here's just an example of fusion versus endocytosis. Fusion requires an envelope. So if you have an envelope virus, its envelope will just straight up merge with the host's envelope and the capsid will be introduced. It's very simple. Versus viral endocytosis, this can be naked or enveloped viruses. It binds to the surface of the host cell. The host cell then endocytoses it for whatever reason. It's now within a vesicle, and then the virus is able to escape the vesicle and infect the cell. Okay, so DNA viral replication and DNA viruses in general. I don't necessarily think it's worth memorizing every single one of these viruses. It's important, but it's a thing that will kind of come with time. However, there is this mnemonic: DNA viruses are happy with all the H's and P's involved. Um, if that helps, great. But really, there's only so many DNA viruses. The vast majority of them are going to be RNA. So this is actually a pretty manageable list for the most part. And really, this just kind of comes with practice and memorization. But the key things to know is kind of how DNA viruses work. The most obvious thing is that by virtue of being DNA, it has to replicate in the nucleus, which that makes sense if you take into account viruses use our replication machinery to replicate. So our DNA replication occurs in the nucleus. So it stands to reason that viral DNA replication should happen in the nucleus. There's one exception to this rule, and that's pox virus. And the only reason for that is pox virus is the largest virus in existence. And it physically can't fit in the nucleus. So it's kind of stuck out in the cytoplasm. That's the only reason it's an exception. Because they use DNA polymerase, it has our built-in proofreading functionality. So DNA viruses are not prone to mutations the same way RNA viruses are, because it uses our proofreading. Another thing about DNA viruses is a lot of the time they are mediated in this temporal regulation process. And what that means is there are kind of three distinct phases of viral replication. The immediate early is basically the virus comes in, it goes to the nucleus, and then that DNA is immediately transcribed into a piece of viral mRNA. And the genes that it produces are going to regulate this whole process to favor viral replication. So these kind of genes are going to shut down host machinery so that all of the focus is on the virus, and it's going to favor the next step, which are the early genes. These are going to be much more involved in maintaining viral DNA replication. And then finally, after the virus has replicated itself multiple times, it will then switch over to the late genes, and these produce the actual capsid proteins to package everything in. And this is all managed by selective splicing and these regulator or mediate early proteins. Beyond the scope of like what you need to know, I would just understand this process. And then once the virus is packaged, it will then either pick up an envelope from the surface through fusion, or it'll be exocytosed to be released from the cell. RNA viruses, on the other hand, function a little bit differently. The vast majority of viruses are in the RNA category, and RNA gets a little bit more complicated, and you then have to take into account, is it positive or negative sense RNA? And I've tried to color code it here with blue representing positive and red representing negative. And all this means is A positive sense RNA means in the pre-packaged virion, the RNA that comes within it is in the 5' to 3' form. So this means that once this RNA gets into your host cell, a normal host ribosome could pick up that mRNA and immediately translate it into a protein. It's functionally equivalent to mRNA. That's all that means. So it comes in, it's translated, you start getting some proteins that might be necessary for transcription and all these kinds of things. And then those proteins will maybe produce an RNA-dependent RNA polymerase, which then allows the RNA to replicate itself and make multiple copies. Everything gets packaged into the capsid, and then it's released. Pretty simple. This virus, once you're infected with the mRNA, it's good to go. Doesn't require any kind of viral polymerase or anything to function. Negative sense RNA viruses, on the other hand, require an extra step. So these come in the 3' to 5' sense, and therefore cannot be translated in their base form by host machinery, because as y'all remember from molecules to cells, it needs to be 5' to 3' to be read by ribosome. So these viruses have to encode their own RNA-dependent RNA polymerase. So that's what this little blue dot in this picture is. So it comes in, this then converts it to a positive sense strand. That is then able to produce all the proteins that the virus needs, and then it is able to then re-replicate itself to create the negative sense copies, which then get packaged into the virion. So really, it's just this one extra step. So the key thing here, positive sense do not require a pre-packaged RNA polymerase. Negative sense do. And really that's it. Because all the RNA transcription and translation happens in the cytoplasm, these viruses never need to go to the nucleus. Of course, because this is real life, there is an exception in that influenza, for whatever reason, likes to go to the nucleus. That's just one of those things you got to know. So pox virus for DNA viruses is the exception. Influenza is the exception for RNA viruses. And again, as far as it comes to memorizing, single-stranded versus double-stranded versus segmented, every now and again, those things become relevant. I did add a couple of kind of just markers to kind of denote that. So the asterisks here refer to segmented viruses. I have never personally seen a question about this, but it pops up in a lot of like the sketchy and board review stuff. There is a mnemonic for it, BOAR, B-O-A-R, for bunyavirus, orthomyxovirus, arenavirus, and reovirus being the segmented viruses. That being said, I don't think that's a very high yield thing to learn, and it definitely won't be on your in-house exam. And as far as the positive versus negative sense, I would understand the concept more than which viruses do specifically. Again, theoretically, you could be asked on that, but it's not what I would put my money on. Okay, so we've talked about DNA and we talked about RNA. Now we're going to talk about retroviruses in that they kind of do both. So retro gets its name from the fact that it starts as RNA and then it becomes DNA. So it does the opposite. In our bodies, we have DNA, which is transcribed into RNA. In the retroviruses, it has RNA, which is then reverse transcribed back into DNA. So this requires a reverse transcriptase, very appropriately named. The thing with this, much like really any of the RNA polymerase in viruses, is they lack that proofreading. So retroviruses, the prototype being HIV, are very highly error prone, which is why they mutate so much and why it's so hard to keep drugs up to date with HIV. And the other thing that's key about retroviruses is they actually integrate into the host cell. So once you are infected with HIV, for example, it has now put itself actually in your own DNA, and it's basically stuck with you for life. Every time your host cells replicate, the now DNA of the HIV replicates with it, which is why we can't cure HIV. We can only treat it by blocking various stages of its replication cycle. So quickly kind of going over that, as with all viruses, there is a binding process, a fusion process. the RNA is reverse transcribed into DNA, and then it is integrated through a protein called integrase into the host DNA. That is then essentially your DNA, and it's transcribed like all of your DNA, which produces viral proteins, which then allows the virus to replicate and wreak its havoc. When a virus is ready to leave a cell, it kind of has a couple of options. The prototypical option is called lysis, where basically you reach a critical mass of virion and it physically just bursts the cells open. They just pop open and all the little viruses release, and then they go on to infect other things. This obviously will kill the host cell. And so these can be very destructive in what they do. Another option in more lysogenic or temperate viruses is to just bud away. So this is actually how viruses with envelopes oftentimes pick up their envelopes. So a virus will replicate normally. It starts producing some of its capsid and envelope proteins, and those will physically move to the envelope of the host. And then when the virus is ready to go, it will just merge with the host envelope and bud off. And now it's picked up all of its glycoproteins and lipid bilayer with it. Here's just a couple of other terms that might pop up on your test. Latent viruses obviously have a dormant stage. This is going to be things like herpes. All of the herpes viridae, in fact, have a dormant phase where they will stay silent for years, maybe, until some kind of stimulus reactivates them. Persistent viruses are ones that continue to replicate but do not kill the cell. So that would be an example of this situation where the host cell is able to keep going and the virus keeps replicating itself, but it doesn't kill the host in the process. So hepatitis is a good example of that. Abortive viruses basically just means the virus is there, but it can't replicate. So really any treatment of, say, HIV would be abortive. So the virus is there, you can't get rid of it, but it's also not able to replicate, and so it can't spread. And then transformative viruses actually produce tumors by whatever their mechanism is. It's essentially allowed unproliferated or uncontrolled cell growth, and so tumors will form. So HPV, polyomavirus are all good examples of this. Epstein-Barr virus has some cancer-producing factors. When performing viral diagnoses, there's a lot of ways you can check for viruses. This is a very busy slide, and like in previous slides where there's a lot of kind of like useless information, I'm trying to highlight the important stuff. So PCR is going to be the main method for diagnosing viral illnesses. PCR being polymerase chain reaction, and RT-PCR being reverse transcriptase polymerase reaction. I'm not going to go into high detail into how these work, but the basic process is you have some kind of polymerase that is heat resistant. You get the solution very high temperature, and it allows that polymerase to go to town on a section of DNA. You run that multiple times through, and then you make millions of copies from next to nothing. RT-PCR, all that does is it uses reverse transcriptase instead of normal polymerase, and so it's able to replicate RNA. That's all that means. So if you're trying to test for an RNA virus, you need to use reverse transcriptase PCR. If you're trying to test for a DNA virus, you could use PCR. I've seen that pop up. As far as all of these other things, these are more historical tests which have been more or less replaced with PCR. In situ hybridization, ELISA, immunohistochemistry, those all require fluorescent staining to stain for specific aspects or to look for antibodies. However, they're kind of tedious and they don't give you like a lot of great data immediately. Serology is probably the next big thing outside of PCR that you might think about. That being said, we don't really use serology to diagnose viral illnesses for a couple of reasons. One is all it does is it detects antibody production at any point for a virus. So if you've been infected with the virus, you're going to develop antibodies to it if you have a functioning immune system. In the acute stage, this can be helpful if you have IgM to the virus. That tells you you have recently been infected with the virus. However, if you were infected with a virus at one point and then you get tested for it later, after you've resolved the issue or had it for a while, you'll develop IgG. That really doesn't tell you anything other than you were infected with a virus at some point in time. It doesn't tell you if you were infected a month ago. It doesn't tell you if you were infected 10 years ago. All it means is you were infected. So it's not very helpful in diagnosing acute situations. There's also the problem where you get false positives or false negatives. There's also something called a window period where the class switching between IgM and IgG actually produces no antibody at all. And so you can get a false negative result where you see no antibody and you say, oh, well, you're not infected. But in reality, it's just because it's in the process of changing over. So long story short, serology, which can be useful, not great. PCR is where the money's at. Everything else here, really not worth spending too much time on, other than maybe just understanding the way they are performed for a kind of historical sense. Okay, I'm not going to go into high detail on hemorrhagic fevers. I only included this slide because there was that one lecture, the ILA on it. The key thing to take away with hemorrhagic fever is the viruses that cause these, as you can all tell, are almost exclusively RNA. They are exclusively RNA. And several of them are also helical. The thing to keep in mind here is many of them have some sort of zoologic reservoir. In Ebola, for example, fruit bats are thought to be the reservoir, whereas in flaviviruses such as yellow fever and dengue, the mosquito is the typical vector. And then the Lassa fever and hantavirus are going to be spread by rodents. The NBME and USMLE love to ask about vectors, so I would pay attention to that. Everything else here is more just to kind of like understand the disease process, but the basic concept is the viruses themselves will infect endothelia of organs. In the situation of Ebola, the virus infects originally the liver, which is a very vascular organ, and then it will go to the actual endothelia of blood vessels. And so you can imagine if you've taken out the cells that form the blood vessels, you're going to get a lot of hemorrhage from them. And this just affects the endothelia of pretty much everywhere in the body. So you get multi-organ failure, hemorrhage, and ultimately DIC and death. We have no way of treating this outside of just making sure folks are hydrated and hoping they can beat it. As you know, this is a very sensationalized and horrible disease. For right now, there's really not much we can do with it. Thankfully, we don't see it here in the United States, and hopefully will not be a worldwide pandemic moving forward in the future. Flavivirus, very similar to Ebola. It's positive RNA, and it is spread by the mosquito. It used to be a huge problem in the United States. We have eradicated it with various vaccination efforts as well as mosquito population controls. Has a very similar presentation. And then arenavirus and hantavirus, you're never going to see these pop up, to be completely honest. They might not even pop up on your in-house exam. Know what's on this slide, but I wouldn't spend much more time than that. Another busy slide over viral oncogenesis. This is going back to that transformative type of virus. This is a good kind of resource, especially going into STEP study within the next year or two, whichever class you're in, to kind of remind yourself some of these things. Epstein-Barr virus, HSV-8, HPV, and then the hepatitis viruses, as well as human T-cell leukemia virus, which is a retrovirus and not HIV, but it is has a similar function. These all can lead to some form of cancer. In the case of EBV and HTLV, that's in the form of lymphomas. EBV infects B cells, HTLV infects T cells. HSV is a AIDS-defining illness in that most of us have a baseline infection of this, but our immune system keeps it suppressed. In a situation where our CD4 cells are no longer working, such as AIDS, you can develop something called Kaposi sarcoma, where basically this virus, it infects the endothelial cells of your blood vessels and causes vascular overgrowth. So you get all of these violaceous lesions shown here. And then hepatitis virus, or not hepatitis, human papilloma virus infects the squamous cells of the cervix and the last third of the vagina. And as it replicates, it also causes the host cells themselves to lose their tumor suppression genes, such as RB and P53. And so they get unregulated growth and can produce these cancerous growths. 16 and 18 are what cause cervical cancer. 4 and 8 are common warts, and 6 and 11 are the benign tumors, such as condyloma acuminata and the laryngeal tumors. And then hepatitis B and C infect the liver, and a lot of times the process of how it replicates causes those liver cells to get uncontrolled growth. Lots of information here. Try to focus on the things in bold. Okay. Quickly going over antivirals. We do not have very many of these because viruses infect our cells. It's hard to target viruses without targeting ourselves too. So the side effect profiles of antivirals are typically pretty unfavorable, which makes treating viruses very difficult, which is why we don't have very many of them. It's great as a medical student because there's not too many things to memorize, but it's not great as human beings who get virus infections. That being said, when we go to treat viruses, the main things we're looking for are blocking viral entry, viral escape, or the actual replication process itself. So these are going to be the things that we shoot to try to block. So the first antiviral we're going to talk about is for herpes virus. These are the guanosine analogs, such as acyclovir and valacyclovir. So if you look at the structure of guanosine and then look at the structure of acyclovir, the key difference here is that the ribosome, or the ribose sugar that is present in guanosine, is no longer present in the acyclovir. So this comes in, it tricks the DNA polymerase into thinking it's guanosine, but there's nothing to connect to moving forward, so it terminates the chain early, and the virus therefore cannot replicate. What's nice about acyclovir and why it's well tolerated is it requires an HSV viral kinase to function. It has to be phosphorylated first. So it's only going to be active in cells that have herpes infection. So this allows it to not impact the cells that don't have herpes virus that you want to keep replicating. That's not to say that there aren't side effects to this drug, but for the most part, it's pretty well tolerated. As far as activity goes, herpes virus is going to be much more targeted than varicella. However, there is some activity against varicella. It has very minimal Epstein-Barr virus and no CMV virus. It can't cure herpes, but it does reduce the severity of the flare-up if you get it early enough into the flare. This is also used in shingles reactivation, so that's reactivation of varicella. Famciclovir is usually the drug you give for that, but you can use acyclovir as well. And then obviously herpes. If you mutate the kinase, the drug will no longer work. And as far as side effects go, it's really, you got to look out for the drug itself will crystallize in your renal tubules. And so you can get kidney damage. The key here is just to maintain hydration so that it doesn't crystallize. So the last one was for herpes. This one is for cytomegalovirus, which is a member of the herpes family, but it is not herpes simplex. So cytomegalovirus functions a little bit differently, so it requires a little bit of a different drug. So this is ganciclovir and valganciclovir. Valganciclovir just being the oral form of ganciclovir. Much like it has almost virtually the same structure as acyclovir, it's just better at targeting CMV cells. Again, requires viral kinase, and ignore this here, and does essentially the same thing. But again, it targets CMV over HSV. And it has a few more side effects. It's a little less well tolerated due to some of the changes. The main thing being myelosuppression and that nephrotoxicity. Viral DNA polymerase inhibitors, this is things like foscarnet and cidofovir. So unlike the previous drugs, these actually bind the viral DNA polymerase itself and allosterically inhibit it, whereas the acyclovir and ganciclovir will terminate the chain. These just straight up turn off the DNA polymerase. So these are used in resistant HSV and CMV. They have quite a few side effects. Again, nephrotoxic. You can give probenecid as a way to kind of help with cidofovir. It helps kind of keep it renal soluble. And then for foscarnet, the thing to look out for is electrolyte derangements, particularly calcium, which can lead to seizures. Again, these are only used really for resistant HSV and CMV, so pretty bottom of the line. Neuraminidase inhibitors, this is Tamiflu, so L-celtamivir, it's the PO form. These block neuraminidase, and they are glycoproteins on the surface of influenza cells or influenza viruses that allow them to escape the host cell. So if you cleave neuraminidase, it's no longer able to escape. So it's able to replicate normally, but it then is stuck in whatever the host cell is. So it has activity against influenza A and B. And you've probably heard, if you've ever had the flu or know someone who had the flu, you have to give Tamiflu early on into the infection. They usually say within the first 3 days of the flu infection. The reason for that is by the time you've reached about 72 hours, the flu is kind of done most of its replicating and has left most of the cells. So if you get it in this first 72-hour period, you catch it before it's able to leave the cells and reinfect other aspects. For the most part, it's well tolerated. Real thing to look out for is just GI issues. Interferon is a historical drug that we used for hepatitis that we no longer use anymore because we have better drugs. Interferon is like the endogenous interferon that your cells normally produce. So interferon alpha and interferon beta are specifically designed to target virally infected cells in your body. So this is what makes you feel like crap when you have the flu. This is what quote unquote flu-like symptoms are. It's interferon doing its work. So the muscle aches, the kind of general malaise that you get from a viral infection is caused by interferon. So you can imagine people that are on interferon for treatment of HCV or HBV feel awful, which is why we don't use these anymore because they were horribly tolerated. So really, this is just kind of a old school thing to keep in mind. It's probably being phased out of the MBME and USMLE at this point. Ribavirin is another drug that occasionally sees use. It's finding its way into treating some more atypical viral infections. This one actually blocks the formation of guanine. So where acyclovir blocked the chain elongation process, this blocks guanine formation. As you can imagine, this can have some side effects, particularly anemia, and it is teratogenic in fetuses. This is used to treat Hep C as well as respiratory syncytial virus. This is a big cause of illness in infants. You'll learn more about that in your pediatrics rotations. Again, this is a drug that kind of has a pretty nasty side effect profile, so we only really use it when we need to. And then there's the new Hep C drugs. And I'm not going to go too much in detail here. As far as memorizing these NS5A, NS5B, NS3-4A things, I think this is beyond the scope of what you'll be asked to know either on an in-house exam or a board exam. That being said, I'm putting this information here for your benefit. So really, these drugs are blocking either the polymerase itself, a protease that's involved in the replication of the virus, or some of the phosphoproteins involved in regulation of the virus. And the names of the drugs tell you which one they are. Again, this is probably more than you really need to know. They have activity against Hep C, and in combination, they basically allow curing the disease. It's revolutionized the treatment of HCV, which used to be a huge chronic long-term problem. We can cure most people with these drugs, and they're really well tolerated. The main thing that we worry about is just, fatigue, headache, GI upset. HIV antivirals. There's a lot of antivirals that go into HIV. HIV is a big problem, and so there's been a lot of research into dealing with this disease. The good news is, while we haven't necessarily been able to cure it, we have made HIV all but cured. So with current retroviral therapy and the way our infectious disease doctors do this, you can keep the viral levels so suppressed that you can virtually live your life as if you don't have HIV. It's even getting to the point where individuals who live with HIV are able to have, sexual contact with other people potentially without protection. That's how well suppressed they can be. So there's a lot going on here. Ideally, you want to use two NRTIs and an integrase inhibitor. We'll talk about what those are here in a second. But the key thing to keep in mind with HIV is it is able to mutate a lot. So you kind of have to play with these drugs a lot. And that's why there's so many of them. Quick overview of the targets. So there's binding and fusion inhibitors. That's miraviroc and enfuviratide. There's blocking the actual reverse transcriptase itself. These are all the NRTIs and NNRTIs. And then there's integrase inhibitors that block, so it's able to, replicate itself, turn itself into DNA, but then it can't integrate into the host genome. So that's what integrase inhibitors do. And then the protease is what cleaves the mRNA into functional pieces that produce, the proteins that it produces. Protease cleaves it into its individual proteins. And so you can block that as well. So several targets. The first one to talk about is the nucleoside reverse transcriptase inhibitors, NRTIs. There's a lot of them here, and unfortunately, don't have great naming conventions. So tenofovir, cidovudine, abacavir, didanosine, lamivudine, stevuvudine, emtricitabine. Unfortunately, you just kind of have to memorize some of these names. The ones I would focus on are tenofovir and cidovudine. But they mimic nucleosides, which means they don't have that 3' hydroxyl group, which would make them a nucleotide. Tenofovir is the exception to this. This one does actually have that hydroxyl group. But they much like acyclovir, will target cells with reverse transcriptase and insert themselves into the chain, causing an early chain termination. Has activity against HIV, is a component of ART. The reason cidovudine is highlighted up here is it is safe to use in pregnant women, and it is the drug of choice when treating mom to neonate maternal transmission of HIV. HIV is able to adapt against these, and it can produce repair mechanisms, which is why you see resistance in these. So it's really important to kind of play around with these and give multiple drugs so that the HIV has to keep mutating to maintain its protection. And usually when it keeps mutating, it loses some of its protective mutations in the process. Main side effects to look out for are myelosuppression and pancreatitis. Didanosine is kind of the prototypical example. There's also a hypersensitivity reaction associated with abacavir. I wouldn't memorize this. That's just, it happens every now and again. Non-nucleoside reverse transcriptase inhibitors, or NNRTIs, there's only a couple of them. Again, I don't have a great way for memorizing these. The sketchy videos are actually really helpful for memorizing the HIV drugs, because they all have weird names and weird naming conventions. So in sketchy, they remind you of the elven women in the Navirapine forest. If that helps you, great. But basically, these allosterically inhibit the reverse transcriptase itself. So they are kind of functionally similar to foscarnet. And so that's why they are non-nucleoside reverse transcriptase inhibitors, because they don't do what the NRTIs do. They do it in a different way, but they have the same effect. They block reverse transcriptase. Navirapine, in your lecture slides, at least in my lecture slides, said can be used in pregnant HIV women. I am not 100% certain on this fact, so I would double check on this, but we don't really use these because they have a less favorable side effect profile than NRTIs, particular rash and P450 induction and inhibition, as well as hepatotoxicity. Efavirenz is teratogenic, and you can get these really weird, bizarre dreams on these drugs. So a lot of times we've moved away from these. Protease inhibitors are the next big class of HIV drugs. These all have a useful naming convention that you can recognize. They all end in navir, 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 navir. So these will inhibit the protease, which is a protein that the HIV uses to break down the transcription products, the translation products into individual genes, or into individual proteins, such as GAG, POL, and all of the GP120s and GP41s. So this actually, the virus is able to replicate normally, but this blocks the proteins that it produces. Ritonavir and these in particular have really bad P450 inhibition. So you have to use, if say someone has a MAC infection, which is an AIDS-defining illness. So say you have someone who has a CD4 count of about 50, you've just diagnosed them with AIDS, and you also need to treat them for their MAC. You would want to give them rifampin, but rifampin is not going to be good enough. You need to use something like rifabutin, which has a less P450 inhibition profile. Other thing to note with the protease inhibitors is they are really bad about causing lipodystrophy. So it can cause android obesity, where you get really big guts and kind of smaller peripheral extremities. This just has to do with the drugs, for whatever reason, cause you to manage your lipids poorly. And so these individuals who are on these drugs are going to have a lot of issues with, say, diabetes and hyperlipidemia, and they'll just have an overall odd placement of their fats. Integrase inhibitors are another class of HIV drugs. So these are actually also kind of named conveniently. They all have tegravir, with the teg of integrase being present to kind of help you remember it. So as we mentioned, the HIV, once it has reverse transcribed itself into DNA, it then integrates itself into the host DNA, and that's what this enzyme is for. So this blocks that process. This is a drug type that we use in a lot of our antiretroviral therapies. And really the only thing to look out for it is the increased creatinine kinase and myositis you see from it. The last couple of drugs for HIV are Maraviroc and Enfuvirtide. Maraviroc, unfortunately, doesn't have a great naming convention. I really love the sketchy depiction of it. It's a knight on his mare guarding the gate to the castle from the invading HIV wizard or whatever. And then Enfuvirtide actually has few in the name to tell you what it does. So Maraviroc binds CCR5 and actually blocks the GP41 binding. So we kind of talked about GP120 binds CD4. GP41 is another binding protein that's associated with GP120 that has to bind CCR5 to finish the binding process. So Maraviroc prevents the ultimate binding so the cells can't infect your T cells. Enfuvirtide blocks the fusion process that happens once that binding has occurred. So it can bind to the outside of your T cells and macrophages, but it can't actually fuse into them. We don't use these drugs all that often, but they do pop up on the boards. Okay, so that's kind of all I've got on antivirals. I'm going to very briefly go over bloodborne parasites. I think for these are pretty low yield when it comes to board exams. For the in-house exam, obviously they're going to pop up, but I would definitely pay attention to malaria, and then I'll point out just a couple of things to keep in mind with some of the other stuff. So getting straight to malaria, it's a pretty complex process. However, really the thing you need to know is kind of the symptoms of malaria. So this is going to be nausea, vomiting, diarrhea, really bad abdominal pain, plus or minus a headache, and then signs of hemolytic anemia. And so if you were to get a CBC on them, their hemoglobin would be low, and you would have swelling of their spleen because of all of this intravascular hemolysis. Other things to look out for are going to be elevated conjugated and unconjugated bilirubin. Again, those are going to be signs of intravascular hemolysis. There's a couple of stages of replication. The specific life stages of the malaria aren't super high yield, but knowing the sporocyte goes to the liver, where it then becomes a merocyte, and the merocytes are what infect the red blood cells. They asexually replicate. They then lyse the cells. They reinfect other cells, and you can kind of see this intracellular RBC life cycle on the peripheral smear. And then finally, once another mosquito comes to do a blood meal, it'll pick up the male and female gametocytes, which then infect the mosquito, re-replicate, form new trophozoites, and the whole process recontinues. As far as the different types of malaria, this is where most of the questions are going to come from. Really, it's going to be distinguishing Vivax ovale from falciparum. So Vivax ovale has the tertian cycle, meaning on the third day, you're going to have the symptoms. And then these are important because they form hypnozoites where they remain latent within the liver for years. So you can have someone who goes, to South America on like a Greenpeace something or whatever. They get sick, but they come back to the United States and they're fine. And then years later, they now have signs and symptoms of malaria. And you're like, why? Why do you have malaria? And then you find out in their history, oh, you were in Greenpeace, years ago. So that's kind of how this presents. They do invade the reticulocytes, but I don't know how important that is. P. falciparum is the very nasty version of malaria. This is what causes the very high mortality rates of malaria. So the reason these are a problem is they sequester within blood vessels. And so this causes things like the cerebral form of malaria, which can lead to strokes and ARDS and just end organ failure in addition to these malaria symptoms. So these folks need treatment fast, and they have irregular fever patterns. Usually you'll see Cortin pop up, or not Cortin, sorry. It's either tertian or irregular. And then P. malarium, the only interesting thing about it is that it's Cortin. Doesn't really pop up outside of that. It has a pretty benign disease process. As far as the antimalarials go, really the key takeaway is just knowing that there's high levels of chloroquine resistance, especially in the Caribbean, Middle East, outside of the Caribbean, Middle East, and Central America. So anywhere in Africa and South America, you need to assume chloroquine resistance. So this means using drugs like mefloquine and proguanyl atovaquone. This is called Malarone. Either of these is appropriate. Doxycycline is also appropriate, but as we mentioned earlier, be careful with the photosensitivity from doxycycline. Mefloquine is nice because it can be used in pregnancy. Big side effect is just really the vivid dreams, and all of these drugs can induce G6PD deficiency, so keep that in mind. If you are concerned for hypnozoites, add on primaquine. It will kill the hypnozoites. And then finally, for really severe infection that's not responding, we use artesunate. This usually has to actually be flown in and approved by the CDC if you have to use it. So it's a pretty rare drug. Beyond that, mostly I would just know the names of these drugs. The mechanisms are probably beyond what you need to know. Babesiosis, I think of this as the American malaria. So babesiosis is a bacteria, it's a protozoan that comes from ticks. It actually shares the same tick vector as Lyme disease. So you'll actually see babesiosis spread with Lyme disease sometimes, which is something that the boards really like to ask about. They're mostly trying to get that you recognize that this comes from the Ixodes tick in the northeast United States. So the thing to look out for when it comes to babesiosis is look for all the signs and symptoms of malaria, but see that the person lives in like the northeast portion of the United States, such as Massachusetts. And then they may or may not have signs and symptoms of Lyme disease as well. And then if you were to see a peripheral smear, you're going to see these Maltese cross, which is just this tetrad form of the intracellular organism. Otherwise, it's almost identical to malaria. You treat it with atovaquone and azithromycin in the moderate versions of the disease, and then clindamycin, quinine in the severe ones. Trypanosoma brucei is incredibly low yield. I highly doubt you will be asked about this. Really, it's just knowing that it's spread by the tsetse fly, and it has a blood phase and a neurologic phase. So in the blood phase, it spreads through the lymphatic and blood tissue, and it causes really painful chancres and lymphadenopathy. And when you get to the neurologic stage is when you start to see behavioral changes, lethargy, and coma, and eventually death. It forms a trypomastigote in the blood. It's these little flagellated entities. These drugs, honestly, not worth your time. Suramin and Malarsoprol, I don't think you'll ever be asked about it. Chagas disease, on the other hand, in contrast to brucei, is actually pretty high yield as far as protozoa go. So Chagas disease is something you'll actually see occasionally in the United States because it's spread by a species of insects called triatomine, or the kissing bug. These are a Central American, South American bug, but every now and again they migrate their way up to the Southwest United States, such as Texas, Arizona, New Mexico. So every now and again you see symptoms of Chagas disease, even in the United States. And then obviously there are people that come from Mexico and South America to the United States, and you'll see this disease in that situation. The key thing to take away from Chagas disease is, again, it is a trypomastogote, but it leads to dilated pathology. And what I mean by that is if it goes to the heart, it causes a dilated cardiomyopathy. This leads to heart failure. And then if it goes to the gut, it can do several things. It can cause achalasia, which is basically the inhibitory neurons of the lower portion of your esophagus no longer work. And so your esophagus gets tightly squeezed and food gets stuck at the bottom of your esophagus. And then megacolon is the same kind of situation, but in the colon, where now you've lost the special neurons that help maintain the colon tone to move feces along. And so these folks will get really swollen colons and stool buildup, and then they get super infected with bacteria and they get really sick. So what I want you to think about when you see Chagas disease is some kind of dilated large organ, whether it's megacolon, achalasia, or cardiomyopathy. Again, the treatments are kind of beyond the level that you'll need to know, but benznidazole and nifurtimox can be used to treat this. And then finally, there's leishmaniasis. This is a pretty rare disease for us to see in the United States. It causes cutaneous leishmaniasis in places like South and Central America, Africa, India, Mediterranean, and Mexico. It's spread by sandflies. And really the thing to take into account for this is just it forms these amastigotes in the biopsies. And you get these really horrible ulcerations, as well as some systemic signs and symptoms as well. You can treat this in severe infections with amphotericin B, but I really wouldn't focus much on this. This is a very niche, low-yield exotic pathogen that I don't think you're going to see outside of this exam. Okay, so that is it on this MedSteps. I apologize for how long it has gone. Obviously, there's a lot of information that needs to be covered here, and I kind of flew through it. If you have any questions about it, feel free to reach out to me. You can reach me at jklucher, that's jklucher.edu, at uams.edu. Feel free to send me any questions, whether it's about this or any other things. Again, thank you for your time. If you have any questions, feel free to reach out to me. Best of luck, you guys.